Jason, do you want to talk about the opportunity for how we can move not just ourselves and our clinics forward, but the entire space of pain care?
Well, certainly. So I've done a lot of clinical research, as John was so kind to suggest, and I'm humbled by the opportunities that I've had in my career to date. And one of the conversations that is common when we talk to some of the device manufacturers and the FDA, frankly, is that for investigator-initiated studies, it's oftentimes really challenging to combine those efforts amongst the practices because there is no common denominator. There is no way that people are consistently measuring outcomes in their patients. And so having a common denominator like a Promise 29 allows for marrying one practice strategy to the other. And we're doing some, I think, really seminal work looking at the Promise 29 scores for pain patients as new patients entering into pain practices across the country to give us some reference on what's going on. Now the question is, how do we use that? And when I think John alluded to this at the top of the call, but I mean when we think about indication expansion in our space, and when we look at FDA guidance on getting indication expansion, oftentimes it does not require a randomized prospective controlled or prospective comparison study. You can do so by acquiring really high quality evidence in the real world. And I can tell you that, looking at some of the work that we've done with some of the emerging technologies in our space, it has significantly lowered costs associated with practice building around research, and then also the large CROs trying to manage this data and trying to mirror the data from one practice to the other. We have the ability to do that in almost real time.
Yeah, thanks, Jason. The one thing I wanted to add is that, oftentimes it's frustrating for us as physicians that we rely on level one RCTs in order to justify the medical necessity of therapies that we believe in our hearts and we've seen in other situations, payer agnostic situations, have been effective. And the concept of Celéri is for us to have a real world outcomes platform that we as a community can use to continuously update our data set to study broad populations that are not necessarily meeting narrow inclusion exclusion criteria, and to start to understand how these devices perform in the real world in real patients, so that ultimately we can understand the right patient for the right treatment at the right time, and do that in a data-driven way that helps us say, this patient's a really good candidate for this therapy, and I have 25 patients in my practice who've responded really well. It's not traditional for this, but that lets you start that conversation to access therapies for appropriate patients that you believe are right for them.
Well, and I would add that one of the challenges that we have here in California is coverage of spinal cord stimulation for failed back surgery syndrome. And so one of the charges that I had when I served as the co-chair for the Advocacy and Policy Committee in AANS was to go to the Division of Workman's Comp and ask, why when we had less data, were we covering spinal cord stimulation? And now that we have more randomized controlled or randomized comparative studies, are we not covering spinal cord stimulation? And their guidance was very simple. It just said that there was too much undue industry influence in how the data was acquired. And so one of the things that this allows is you to capture patient outcomes as a clinician with your patient, and avoiding that third party potentially of data massaging around device performance. And so having removed that segment of the potential influence on data-driven outcomes, getting the information directly from your patient is vital. And I think that that's part of what this provides.
And, again, this is not novel. So Jason and I, and there are lots of people who say, well, I can do this in my practice. I can capture a Promise 29, and we'll show you shortly that we were doing that. We were doing the work. We were doing data capture on pieces of paper and inputting them into spreadsheets and trying to track that over time. And what we recognize is that there's a real gap in the ability to capture that data with very little work to automate the structuring and standardization of data such that essentially your practice will function as the clinical trial. And as we mentioned before, real world evidence is nothing new, but it has been expanding dramatically in terms of the support, both from the US FDA as well as the other regulatory components for device, but also in pharma. And each year, the number of real world evidence studies rises dramatically.